Yeah, I'm so indebted to you all. The Seattle Science Foundation has just been masterful, particularly on this topic of the multimodality treatment of spinal tumors. And I think Udi hit it right. You know, we have often approached these more as oncologists than from the spine. The spine just happens to be, the area that we are addressing, but really the oncologic issues are so important. And I think the two quick sides from this morning, I think for Pancoast tumors particularly, the technical issues are really interesting, but the thing that actually changed the outcomes for those patients were neoadjuvant chemoradiation, which took the overall survival from 15 to 60% 5 year. And so surgery is additive, but much like what we're going to talk about today in chordoma, I think we finally have data that pretty well assures us that radiation has to be integrated into this treatment paradigm as it has been with multiple other primary tumors. Let me see if I can. I think there are two misconceptions about chordoma. One is that they're surgically curable with en bloc resection alone. And in point of fact, some of them are, but it's often very difficult to achieve an en bloc resection with wide margins with acceptable morbidity, in part due to anatomic constraints, such as this patient with high-grade cord compression, bilateral vertebral artery, and this large parapharyngeal mass. And then we consider these to be somewhat high-grade sarcomas because of the ubiquitous presence of satellite and skip lesions that often give us very early marginal recurrences. And then 30% of these patients will eventually metastasize widely. The second misconception is that chordomas are resistant to radiation. In point of fact, they are resistant to conventional radiation that we use for metastatic disease, such as 30 gray and 3 fractions. But it turns out that they're exquisitely radiosensitive to high-dose radiation greater than 70 gray BED, which you can give as greater than 70 gray and 2 gray per fraction, or 24 gray single fraction has a BED of 84 gray. But to deliver these radiation doses, you need advanced radiation techniques that spare spinal cord tolerance, such as proton beam, carbon ion, or photon-based SBRT, such as volumetric arc therapy. How do we do with en bloc sacrectomy as a standalone? Here's our series from Memorial from 2009 of 42 patients who underwent an en bloc excision, of which they achieved wide margins in 63%. The 5-year local control, despite that aggressive surgery, was 60%. The complication rates were 74%, principally loss of bowel and bladder function. 15 years later, MD Anderson presented their data of 50 patients who underwent en bloc excision, of which they achieved marginal or wide resections in 82%, and their number is exactly the same. 5-year local control is 60%, with complication rates, again, of 62%, mostly with loss of bowel and bladder function. So essentially, the best you can do with en bloc sacrectomy is about a 60% 5-year local control, particularly for those patients who need high sacrectomies with extracompartmental tumor. There's been some controversy that there is no radiation data long-term with complications in chordoma, but in point of fact, this is a series from Kristen Redmond looking at radiation outcomes in chordoma, and there are over 2,000 patients in the literature looking at proton beam, carbon ion, or SBRT. Two of the more interesting studies that have come out recently, this is from MGH, from Joe Schwab, of 76 patients, principally in the sacrum, but some in the mobile spine, undergoing en bloc resection with 2-dose cohorts of radiation greater than 70 gray RBE versus less than 70 gray. And in that cohort that got greater than 70 gray, the local recurrence-free interval was 90%, 93%, which was significantly better than less than 70 gray. And margin status fell out as a significant variable. So it didn't matter whether you had an en bloc marginal or wide versus intralesional. Margin status is out of the equation if you get greater than 70 gray as an adjuvant radiation therapy. Here's a series from Johns Hopkins of 101 patients, both mobile spine and sacrum. They achieved en bloc wide or marginal excision in 87%. 22% of their patients got neoadjuvant radiation. They had 75% local tumor control. The impact on local tumor control was tumor volume, spine level, and sex, but the biggest one was actually neoadjuvant radiation therapy. With the addition of neoadjuvant radiation and en bloc resection, there was a 10-fold reduction in local recurrence, and there was no difference between EA and EI resection. Essentially, you could have a positive margin resection, and if you added radiation therapy, you got excellent tumor control. And in en bloc excision, again, there are major complications, in this case, about 65%, which is expected. The question may not be whether how much radiation adds to surgery, but how much surgery actually adds to radiation in chordoma. There's over 600 patients in the literature that have gotten definitive radiation, and those series are really interesting. Here's a series from Japan of carbon ions in the sacrum, 188 patients that got about 70 gray and 4 gray per fraction, and their 5-year local control was 77%. Their complication rate was 4%. So with no surgery, they did better with en bloc resection in terms of local tumor control at 5 years with less morbidity. Here's a series of definitive proton beam for the sacrum from Mass General, 24 patients. Most were for high sacral tumors that were unresectable for cure in their estimation. They got 77 gray and 2 gray per fraction, and their 5-year local tumor control was 80% with no surgery. Complication rate was 16%. Here's another series from MGH, an updated series of 7 patients, principally with sacral tumors, but 15 in the mobile spine. The median dose again was 77.4 and 2 gray per fraction, and their 5-year local control was 81.8%, 82%. Complication rate of 30%. Mostly were insufficiency fractures with some neuropathy. And again, these sacral insufficiency fractures, particularly, we can now treat the pain with cluneal nerve ablations without the need to have them recover from those. They essentially can get a cluneal nerve ablation, and those patients are typically up and walking the next day without other interventions. The question has been whether carbon ions are better than proton beam for sacral tumors, and there's some sense in the literature that that's true. Here's a series of 82 patients that were randomized to carbon ion versus proton beam at a relatively low dose, 4 gray and 16 fractions. And there was no difference in local progression-free survival at 4 years, 70%. Again, that 70% is probably because the dose was a little bit lower than we've seen in other series. And again, they do see insufficiency fractures in the sacrum from the radiation. But again, these are relatively easily treated. There's some skin toxicity, grade 1 and 2. And the neuropathy was not loss of bowel and bladder, but principally grade 1 and 2 and 44%. If we look at the mobile spine, most of the data on surgery comes from the AO Spine Knowledge Forum. This was a retrospective study over 35 years of 166 patients, of which they included recurrent tumors in 30%. In terms of the resection, 40% underwent an onyc inappropriate, was en bloc for marginal or wide resection, and 60% had an onyc inappropriate, which was either en bloc or curettage intralesional. Radiation was given in 50% of patients, and you see these beautiful curves where A resections did significantly better than EI. There are a lot of problems with this study, but one of the biggest problems is that adjuvant radiation was asked as a simple yes-no question and didn't account for conventional external beam radiation that we use for metastatic disease versus protons, carbon ions, or SBRT, and there's certainly a significant selection bias in who received radiation. And then one of the bigger flaws, again, was with this en bloc resection of these tumors, that there was no discussion of morbidity. One of the more interesting studies that started to incorporate radiation therapy was a study from Italy, 33 patients, chordoma of the mobile spine, where there were 2 cohorts. One was en bloc excision as initial therapy for patients. The second cohort was actually at recurrence in those patients who underwent a curettage intralesional, followed by either carbon ions and proton beam. So you take the best case scenario of initial therapy with an en bloc wide versus that first recurrence with a curettage intralesional followed by radiation therapy, and there was no difference in local tumor control between those 2 cohorts. We got interested in photon-based SBRT, single fraction radiation, based on a single case. This was a patient with an L3 vertebral body lesion with some extra compartmental extension, but too old and too sick for an en bloc resection. So we gave 24 gray single fraction radiation. And here's the 4-month follow-up film where we did an intralesional resection based on what we thought was radiographic progression. And it turned out the tumor was 99.9% dead from single fraction radiation. So that made us look at a series of 35 patients with de novo chordoma of the mobile spine and sacrum who received single fraction radiation over a 10-year period. Half of them were in the mobile spine, half in the sacrum. Half of the patients received the radiation as definitive therapy, of which 8 were in the sacrum. In terms of the surgery, 10 patients underwent neoadjuvant radiation followed by en bloc sacrectomy. And then in patients with high-grade cord compression with or without myelopathy, we initially started out with curettage, gross total, intralesional resection, and then as we got more comfortable with outcomes of radiation, we began to do separation surgery for those patients. The median dose was 24 gray single fraction, and again, a third of them got it as definitive radiation with no surgery, a third neoadjuvant followed by resection, and a third postoperative adjuvant. In the patient cohort that got 24 gray single fraction, the 5-year local control was 90%, regardless of what other treatment they got. So whether they got it as definitive radiation, a postoperative adjuvant, or neoadjuvant, the radiation dose defined the outcome in terms of local tumor control. What we did in this series was we took that AO mobile spine series and we took not the Anakin appropriate and moved that curve down. We took the Anakin inappropriate and moved it below the Anakin appropriate by integrating radiation therapy. In terms of morbidity, most of the morbidity was related to en bloc sacrectomy with loss of bowel and bladder function. There is toxicity from radiation, 17% grade 3 toxicity late. Most of these were easily fixable with small procedures. The one that was not was a treatment-related secondary malignancy in a very large chordoma, which ended up having a transformation to a rhabdomyosarcoma. And we think that this is a single series from a single institution, and it may not be all that meaningful, but MD Anderson used exactly the same strategy we did at 24 gray single fraction in 15 patients, of which 12 were chordoma, and then they included 3 chondrosarcomas, principally the mobile spine, and then some in the sacrum. And most of these were used as definitive therapy, so 95% of them received radiation alone, and their 5-year local control is exactly the same as we got at 24 gray single fraction, 90%, and the complication rate, again, of 23%, mostly with fractures related to the radiation. So proof is in the pudding. Here's some case examples. Here's a patient with a distal sacral chordoma, got 24 gray single fraction. Here's a 4-month follow-up film with no evidence of residual recurrent tumor. Here's a patient who underwent an MR brain for forgetfulness and picked up this incidental C2 chordoma. We gave 24 gray single fraction as definitive therapy. Here's a 9-year follow-up film with no evidence of residual recurrent tumor on standard MR imaging. Here's a patient from Brazil who asked us for a recommendation regarding this C2 chordoma. We recommended 24 gray single fraction. Here's a 4-year follow-up film with no evidence of residual recurrent tumor on standard MR imaging. Here's a 64-year-old female with T1 radicular pain that had this this T1 predicated chordoma. We gave 24 gray single fraction. Here's a 5-year follow-up film with no evidence of residual recurrent tumor. Here's a patient with widely metastatic chordoma that had previously been resected in 2022 and then presented with, again, widely metastatic disease. She had significantly high-grade compression, ESCC score 2, but not a candidate for surgery. We gave hypofractionated radiation 30 gray and 3 as definitive therapy. And the 2-month follow-up film shows complete resolution of the epidural disease. These tumors are exquisitely radiosensitive if you give a high enough dose of radiation. Here's a 57-year-old female, 6-month history of clumsy hand syndrome with C5-6 vertebral body disease and very high-grade cord compression. We did an intralesional gross total resection followed by 24 gray single fraction. Patient remained neurologically intact. Panel C shows a 5-year follow-up film with no evidence of residual recurrent tumor. Here's a patient with a T11 chordoma with ESCC grade 1C. We didn't think we had enough room to give 24 gray single fraction, so we did simple separation surgery followed by 24 gray single fraction. Here's a 6-year follow-up film with no evidence of residual recurrent tumor on standard MR or DCE imaging. Here's a 53-year-old football coach presented with high-grade cord compression and significant myelopathy, lower extremity weakness and numbness, requiring a walker. He was taken in an outside hospital for emergent separation surgery that got excellent recovery of neurologic function, and you can see this T10 vertebral body disease with 2-level high-grade epidural compression. They did really excellent separation surgery with a standard reconstruction in the metastatic population. With this decompression, they got neurologic recovery, and the tumor ended up being chordoma. We didn't have enough room to give ablative radiation at the margin of the cord, so we took them back for our re-decompression and then re-instrumented with a vascularized rib graft, dual rod construct, and cement augmented screws, gave 24 gray single fraction. Here's a 4-year follow-up film with no evidence of residual recurrent tumor on standard MR or DCE imaging. Here's that original tumor that I showed you, the 54-year-old female with a high cervical myelopathy, clumsy hand syndrome, with a C2 chordoma, high-grade cord compression, bilateral vertebral artery disease, and this large parapharyngeal mass. Again, not a candidate for en bloc resection for marginal or wide to be curative. We took her for simple separation surgery to reconstitute the thecal sac and left all of this epidural tumor behind in the parapharyngeal space and along the vertebral arteries. Gave 24 gray single fraction. Here's a 7-year follow-up film with no evidence of residual recurrent tumor. In Kristen Redmond's paper, we're now giving recommendations for radiation based on the treatment strategy for protons or photon beam therapy at 1.8 to 2 gray per fraction. The recommendation is to go to about 76 gray. For single or hypofractionated radiation using SBRT, 24 gray single fraction or 40 to 50 gray in 5 fractions. And then for carbon ion, it's usually around 70 gray and 4 gray per fraction. Instead of trying to take out more tumors, we're trying to make better targets for ablative radiation. Oftentimes the bowel is plastered to chordomas in the sacrum. And now we'll put saline boluses into the retroperitoneum to get the bowel to float several centimeters away to make a better target for the radiation. In the cervicothoracic junction, tumors that abut the esophagus, will have the thoracic surgeons go in and put a hydrogel spacer between the esophagus and the tumor, again, to give an ablative dose without injuring the spinal cord, creating an esophageal perforation. In terms of metastases, we're starting to manage these in the spine like we do for any other metastatic tumor. In this case, there were several levels of metastases, but one level of high grade where we did separation surgery and then treated every level 40 gray in 5. And at 6 months from this strategy, the patient had stable radiographic features. There are cases with widely metastatic disease where the radiation isn't enough, and we clearly, like in this case, need systemic strategies to help manage these patients. This was a patient who came in, they'd had a clival tumor initially, got resected, recurred and got gamma knife and Gleevec, which has not been all that useful in chordoma as best we can tell, then presented with this widely metastatic disease. We actually weren't able to do separation surgery in this area to get this decompressed. So we actually did transmandibular osteotomy, took out all of the tumor, anterior and posterior, and then did occipitocervical fixation, and then took the patient to radiation therapy. But the intent with this patient, because it was so widespread, was potentially to do radiation with checkpoint inhibitors. And unfortunately, the morbidity from that surgery was prohibitive, and the patient actually committed suicide before getting to that treatment. We're super interested in the combination of checkpoint inhibitors with radiation for chordoma because there are a lot of PD-L1 receptors on it. This was actually a renal cell, twice irradiated, that failed. And we didn't think we could give an ablative dose of radiation due to skin toxicity. The patient was kept on dual checkpoint inhibitors, and only the center core of that tumor received a radiation dose at 27 gray and 3. So 2/3 of the tumor received no radiation dose. At a month, you can see the necrosis in the tumor, and by 2 months, you can see the DCE images show the tumor is completely dead. We've just completed a chordoma study looking at PD-1 inhibitors in combination with radiation for recurrence, and apparently there's a pretty good signal there, although I haven't seen the data to date. But there are a number of systemic strategies that are being worked on from a number of avenues, molecular and immunotherapy. And in point of fact, for a disease that's 1 in a million in the population, these are the number of NCI trials going on for systemic therapy in chordoma. In principle, I think chordoma to us is classified as a high-grade sarcoma based on microscopic satellites and the potential for metastases. En bloc surgery for marginal or wide margins is often not feasible due to these anatomic constraints and prohibitive morbidity. And my maxim is in the spine, you just can't be wide enough to cure them. Surgical advances such as 3D modeling and printing will not improve outcomes because ultimately you can't overcome bad biology with more aggressive surgery. The carbon fiber implants, which have been talked about today, are really meaningful in chordoma, mostly because post-op protons and carbon ions are now possible, which really weren't with titanium. For SBRT, photon-based, it's really, I think, radiation oncology centric, whether they want you to use carbon fiber implants, whether that improves their dosimetry. For us, it's not really meaningful, but for many centers, they'll insist on carbon fiber for photon-based therapy as well. For radiation, you need to get to a BD greater than 70, which is ablative and makes chordoma what we think we can now call exquisitely radiosensitive. Radiation compared to en bloc resection, it's better local control, whether it's used as neoadjuvant, adjuvant, or even definitive radiation. And with radiation, we overcome a positive margin status, which allows us to do separation surgery. If you look at the 5-year controls for sacrum, it clearly, the addition of radiation is meaningful. En bloc alone gives us 60% in every series reporting, and surgery plus radiation takes us up to well over 90%. Radiation alone gets us to 90%. So we think at this point there's probably a 10% benefit to surgery in the sacrum. In the mobile spine, if you do the best surgery possible with en bloc resection, with a negative margin resection, the best you're going to do is 84%. And then with surgery plus RT or RT alone, we're upwards of 90%. We still need better systemic options for the inevitable metastases that occur in 30% of patients. So where do we stand today in terms of current recommendations? We will never have prospective data in this patient population, and it's been tried in Europe for the sacrum, and they simply couldn't accrue because if anybody thinks there's parity, nobody's going to go through an en bloc resection. We present patients with radiation data and the countervailing surgical dogma, but I can tell you last year at Memorial, we treated 10 chordomas with definitive radiation with no surgery, with the expectation that it's less morbid, with at least equivalent, if not better, tumor control. And so if you're in an institution and you don't know really what to do, that you get this chordoma, our recommendation now is to refer to an institution that routinely deals with these tumors, not simply to get a recommendation for en bloc resection, but to get a global assessment of whether radiation would be meaningful in that patient population. And with that, I thank you.
Great talk, Mark. It's always these difficult cases. These chordomas are, this en bloc versus is radiation really the next frontier of dealing with this type of patients. So as you are seeing the data that you have spearheaded when it comes to this radiation option for these patients, you broke through many walls, right, that are out there in a sense of en bloc resection is the way to go with these cases. Do you now to the point where you feel that you got a patient with a thoracic chordoma, it's in the vertebral body, it's feasible to do en bloc resection, it's also feasible to offer it with radiation. Do you offer your patients the option? Do you think that an en bloc is reasonable for this type of patient population? I'm not going to the patients who have, loss of functionality, bowel bladder, those kind of things. But the conventional en bloc resection for a mid-thoracic chordoma, how would you go about dealing with a patient like that? Would you feel that radiation would be a reasonable option for this patient, or you think that an en bloc would be the way to go and something that can be resected with no neurological deficits or significant complications?
Yeah, I think it's a great question. I think for the first time this year, we have data from really every major cancer center that at least shows the utility of radiation, even as definitive therapy, including, this year Anderson came out with that data. So it definitely, you can offer it, especially in the older, sicker patient, and many of these patients are certainly in their 70s and 80s and may not tolerate an en bloc, that there's at least parity in that patient where you could do, a definitive en bloc with a wide margin status that curative resection, that we think there's parity with radiation as definitive without resection. The converse, I guess I would say, is that if you can avoid radiation and they can tolerate an en bloc, it's not unreasonable at all to offer that as well. But I think what we have found, in principle is even for the sacrum at 5 years, you're getting a 30% incremental benefit from the integration of radiation. And at least on the photon-based SBRT, both from us and from Anderson, um, we're about 90% local tumor control. Carbon ions and protons are in that 70 to 80% range. So realistically, what you're talking about with en bloc plus radiation, not en bloc alone, but en bloc plus radiation, is a 10% incremental benefit. And whether it's worth the morbidity of that or not, at this point, I don't think it is. So the answer to your question is, yeah, we do offer. If you had an intracompartmental, not notochordal arrest, but definitive chordoma mid-thoracic that's resectable, we would probably offer both with great confidence that the radiation is as good, if not better than en bloc. And now, I think for years we've been sort of dancing around it. We had data, but now every major institution from cancer has shown a benefit to integrated radiation, and many of them as standalone therapy. And so I think we're pretty confident in that recommendation now. And as I noted, you know, if they have high grade compression and they need separation surgery to give ablative radiation, we're going to take them. We did 10 last year alone with definitive radiation with no surgery, so we're pretty confident in those recommendations at this point.
Yeah, that's why I was asking. Just the conventional vertebral body chordoma with no need for separation surgery, where an en bloc is definitely feasible versus how you go about doing it. And there was a reason why I put Zia after you, and Zia is right there on the call. And I think it's always interesting for all of us to listen to this dogma, right? When we see these patients. And I think it also depends on where the patients are being seen, right? The capabilities that are available, let's say at Sloan Kettering versus other places. Are you able to deliver this high dose radiation safely? Clearly you can do it at Sloan Kettering, and hopefully it can be done at many other places. Zia, do you have anything to add before you're giving your talk about your thoughts about the typical?
I always enjoy Mark's talk, and I learned a great deal from that. So I respect him immensely. I think there is some truth to what he's saying, and I think there is emerging data that would support that the radiation will play a larger role in treating patients with chordomas. Having said that, in cases as you are describing, I think the surgery still remains to be the gold standard. Just to give you two examples, two of my patients, both with sacral chordoma, were seen, one in Germany for carbon ion radiation, another one after surgery by Josh Shibata at Sloan Kettering, just recently following an en bloc resection with negative margins. One of the patients who did not have surgery yet decided to go to Germany to get a second opinion for carbon ion. And as you know, the carbon ion results are outstanding. He was recommended that he gets his tumor resected. They did not recommend carbon ion radiation for the tumor. The second patient who had an en bloc resection who had negative margins, I sent the patient to Josh for him for consideration for an adjuvant radiation postoperatively, and he recommended no radiation and just followed the patient with serial imaging studies. That goes to show you that some of the things that we believe sort of the standard is not necessarily always the standard when the patients are individually evaluated. But I think I put some additional slides in my talk when I was seeing Mark's talk here. You can look at the data in different ways and draw your own conclusions. Many of my patients are seen by Mark. I've seen by Josh and many other proton beam or stereotactic radiosurgery centers, and many of them settle on surgical treatment, and some of them decide to choose alternative routes. So all of these options, I think, need to be presented to the patients and educate the patient, and then let them make the decision in terms of what's best for them.